Welcome back, everybody, to Value Based Care. Today I have Lee Lewis with us, who is Chief Strategy Officer of Health Transformation Alliance. I also have seen some of your very interesting, your own podcast, Broken Benefits. And so I am thrilled to have you today because I feel like even though I'm the doctor in the room with the patient, you're really in all those other rooms. I feel like, how come I'm not there? I have no idea what's going on. And it's where I should be to really truly advocate for patients. So I am so excited to have you. Would love to know more about you on behalf of our audience. So yeah.
Oh my gosh, no, it's great to be here. Thanks so much for inviting me and excited about today's conversation. Just for context, the group that I work with, it's on the employer side who are paying for all of your services and the services of your listeners who are treating patients. And we also are absolutely fed up with the system. We want to change it. And you may not believe this or know this, but we actually really care about the doctors who are taking care of our employees. And we want to take great care of the doctors. In fact, our mantra is we need to pay people, not buildings. We need to pay doctors more. We need to help them to have better lives and stop getting absolutely destroyed by pharma and facility. But kind of a fun thing. So it'll be a fun conversation.
No, I loved how you said that you have to pay people and not buildings, because just that image hits me so hard sometimes, where I do feel like when it comes to healthcare, we're supposed to be all taking care of the patient, and yet at the same time, I don't get the sense patients feel like they are the ones who are being answered to. And we do get these really nice hospital buildings, and there's all these brands, but it never really, to patients, feels like they're being spoken to. Like, how is this supposed to help me? And
Yeah.
so I love being able to get your point of view, and you seem like someone who, like me, just speaks super directly. And would love to know more about your work and how you're helping bridging this gap, where I feel like as a doctor, I have this all these things that are hazing my vision of how I can
Yeah.
actually truly help the patient in front of me.
Yeah. Okay. So we'll start at a high level and then we can go deeper in. So the first thing that we are thinking about, so our thesis is that if we want to transform our healthcare system, well, like, and what is that? It's getting to an 84, 85 year life expectancy like other countries have and doing it at half the cost. That would be like a poor man's good definition of what a transformed healthcare system would deliver as a consequence. And those are both achievable. Switzerland is lots of countries are hitting 82, 83, 84, 85 lives or 85 years of life expectancy, and they're doing it at 50 to 80% lower cost. So like we've got a vision of what it could look like. And we think that the active ingredient to get us there is if we can realign the incentives. Uh, One of the sort of the great authors from the medical side, from your side, said a wonderful quote uh, once, and that was the difference between a good doctor and a bad doctor is 6 months and clear feedback. If we can provide good feedback, visibility, transparency on practice patterns, and we can pay physicians to do the right thing, and where they earn well and succeed, keeping patients happy, healthy, and out of buildings and facilities, that realignment of incentives, we think that that could very quickly change our whole system if we can realign the incentives.
I've heard that before in other ways too. I think it was even Charlie Munger who said, show me the incentive and I'll show you the outcome. And so our
Yeah.
outcomes are reflecting our incentives. But I could see that you were thinking very deeply, and then I jumped in because I just can share with you already, and even though you're not a physician, I can
Yeah.
share that passion that I can see in you, that you just really want to be able to have really true care, like care of people, and
Yes.
pull back all, like everything got so complicated and just couldn't go backwards from it. And
Yeah.
so I really want to be able to, and I feel like I'm jumping ahead, and I just want to ask that question of, you know, how did we get here?
Yeah. I think, yeah, no, going into the incentive misalignment is, like it or not, we accidentally ended up with some bad incentives. But bad incentives can beget worse incentives as you start to follow along a path. And opportunism, when it opens itself up, that's an easy place for it to go. And human nature is persistent. And within healthcare, it's easy to justify things that it might be harder to justify in another space. But if you've got a savior complex and say, hey, I've got to pay for a cancer complex to save lives. Okay. So getting money through any means other than directly eliminating someone will let me build something that saves lives. And so now I have this ultra extreme moral imperative that I've created for myself to get money through any means other than murder, basically, because I'm saving a life, right? So almost anything is justifiable. If I'm doing it to save a life, almost anything is justifiable. And so it massively expands the range of human behavior that would be shady in another situation, but we excuse either to each other or to ourselves because the stakes are so high. It's just like anybody, like, is it okay to speed? No. Well, what if I'm having a baby, right? Oh, well, then speed, right? Like, you can excuse so many behaviors if you just increase the stakes. And in healthcare, the stakes are at the highest level imaginable. And so nearly any really scary behavior can be self-justified. And so that's where you run into a cascade of bad incentives can beget worse ones. And that's where we are fighting. It's an uphill battle, but we are fighting to realign those incentives to help pay people for getting the right outcomes for patients and stop paying for things that do not accomplish that. And if we can push enough in that direction, I think we'll start to turn the system around. I'm wildly optimistic in this, although realistically acknowledging it's extremely hard. But that's our thesis, and we're operating along that. And so we've established, like, okay, what got us here, and and what might we do to try and turn the ship. And so now on the employer side, I am not in the room with the patient ever. I'm not in the administrative suite with the hospital. Like, I don't have any visibility in anything on your side. I have visibility into a couple areas. How we structure the insurance and pay for things. And I have some visibility into how we create plan designs that maybe help people to do some things that are good, like getting my annual physical. I can pay someone to do that. So I can incentivize a little bit behavior. And I can also work to choose which networks and which hospitals and doctors and things like that we have, and have a little bit of impact on what's covered. So those are kind of the levers that I have on my employer side. Okay. And within that, there's high level, and then we go deeper. So the first thing that we want to do is we want to disabuse ourselves of three false dogmas. The first is that healthcare is always a fixed cost. You can't do anything about it. Executives believe that. Business leaders believe that. They're like, you can't stop Randy from getting cancer or falling down on the ski hill. Can't stop it. It's unpredictable. So why try? That's the first false belief. The second one is an extension of that, and it is saving money in healthcare hurts people. It's like, well, why do you believe that? Business leaders, they may not say it like that, but they believe it. They think, oh, if I'm saving money on healthcare, it means either A, if we believe it's fixed, it means I'm either increasing deductibles and premiums on families who already cannot afford it, or B, maybe I am telling people that they can't see their doctor and I'm narrowing my supply chain and I'm telling them they can't see other doctors and they have to leave all their relationships. That's horrible. I would never want to do that. Or C, maybe I am sending them to like the cheap place and I'm sending them to like, you know, two-bit leech medicine, whatever, like not real healthcare or like, cut rate healthcare that's going to hurt people. And so business leaders don't even want to talk about saving money on healthcare or changing the way they do things because they feel like saving money hurts people. And then the third thing, the third dogma, especially coming out of the first two, the third is that it's never worth the squeeze, that it's never worth it to even try. So they end up saying, you know what, just keep doing what we're doing, stay in the status quo, keep us in the herd and keep it quiet. And that then surrenders all the decision making to insurance companies. And the decisions they make.
Yeah, that's incredibly revealing, especially as I am thinking about as a doctor. I am part of a group practice, and
Yeah.
so it's run by physicians. We're not a hospital, we're not some health system, and but we have hospitals around us, and we run into similar dynamics of being people who can cut down costs, we can get patients in quick, we can personalize what they need, we can
Yeah.
figure things out creatively, like, oh, you don't have to go to this place to get a scan because we're gonna be neutral and just pick where, not like, oh, you have to go through my system. And yet, I find, and I don't know everything about payers or the
Yeah. Yeah.
relationships that payers have, but I don't find that I'm always their top choice compared to the hospital or an academic center. Or
Right.
if I'm trying to communicate to my patients, it still seems in their mind there's some other story going on that I'm never really able to climb upon, even though I'm a
Yeah.
physician in front of them. So it's so helpful to know what you're saying. It makes me think as physicians, maybe we need to be even more involved from the viewpoint of talking to employers or somehow, playing more of a role there. I'm trying to understand how employers even look at us. Like we
Yeah.
must be like an interesting species to them.
Yeah. 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 Employers know emotionally that there are really good doctors and nurses behind enemy lines who are doing amazing stuff. Like they understand that. But when we hear the story of somebody getting like on a deep stage 4 cancer, they get sold, when they've got 6 weeks to live, they get sold some new $1 million drug that takes them to 7 weeks. It's like all the trust and the faith of all the good that is being done gets eroded by bad apples that these sort of really bad use cases that just leave a psychic scar, right? It's like, ugh, there's just bad stuff happening over there and it erodes that trust so much that it's like a lot of times we find ourselves into a defensive position where it's like, man, how do we is there anything good? It's like, ugh, even the innovations that are coming in healthcare, it's like it's all going to bankrupt us. Every new thing that comes out, we call it the 10 by 10 rule. It's 10% better for 10 times the cost. And you're going to bankrupt us. And we have to apply the same innovation principles that we have in toasters and TVs and other types of technology and software and cars where you get way, way massive improvements in product and outcomes for rapidly de-escalating prices. And that innovation never seems to make it to healthcare, but it's something that we need, that we're trying to espouse.
Yeah, and it almost is an impossible ask because you were outlining the dogma of, well, if you try to make it cheaper, then we just made it worse, or employers are picking a worse plan. So it's just like a never ending erosion of trust. But, and I love that you said that because that's a lot of what in my community, what us community physicians are trying to do is rebuild trust, is we recognize patients are coming in and they have all of these stories and research they've already done and they're looking at us like, okay, so what are you going to do that is just to make money? Or they heard another story about someone had something bad happen to them, and we're going to do that to them. And there's a lot of trying to just take the fear down
Yeah.
and understand where did your fear come from. Before I even start medicine, I start understanding the person's story. A lot
Oh,
of my time in
keep
clinic is
going.
actually not medical, and I
Oh,
very much,
interesting.
yeah.
Now, unpack that for me. So, you need to hear their story. Is it to gain trust so that you can work with the patient because they're not gonna if they don't trust you, they're not gonna follow what you say anyway. So you don't get anywhere. You're wasting your time, or is it part of the healing process, letting them get their story out? Help me understand that.
Yeah, I think definitely both, but more the first one where I can already tell, and it's certainly not everybody, but it feels an increasing prevalence of this distrust of, oh, I'm being forced to see this doctor because my insurance or my employer or whoever, this is where my geography put me. I don't really know if I trust this person. And they'll go on the internet and try to look the person up and try to put it together like, oh, is this someone I'm gonna be compatible with? And they come in and I'm already just trying to even gauge the audience in the sense of what have they already created in their mind? What story do they have in their mind? So I can't even really jump into talking about cancer without being sensitive to what kind of conversation do they think they're even in, because that conversation is going to be colored by what they're already expecting. And so a lot of my time is I actually and I know this usually creeps people out when I say this. I actually during COVID, that was such a striking time in my career that I realized our communication skills as doctors really were never given to us as a fundamental. And I really had to build that for myself. And I learned from former FBI hostage negotiator on on empathetic communication skills, and that just changed everything for me. I feel like I got through COVID so much better, and I could build trust even wearing all that prophylactic, like the masks and having to distance from people and having to have one person and can't have their family members. But just recognizing that people really come to our building, which actually says the word cancer on it. And so they're already triggered. They're already thinking the worst. They're probably already thinking, what do I do for the person I'm supposed to be caretaking? And they have all of this coming to sit with me. And I have to be very sensitive to that because I could say something that to me is very neutral but just set them off like, oh wow, that doctor is the worst because I didn't take a temperature on where they're at. And so I find that everything you're saying makes so much sense and it's so validating to hear. And also amazing to feel that you're working on your end to try to change the healthcare system too. And it makes me feel like the collaboration is we all want to work together and yet there's gaps like the ability to bridge those so that we're not all recreating. Well, we see the problem and we're recreating solutions when we could be working and amplifying those solutions together. That's what I'm constantly trying to search. And the more I search, the more I find it actually makes me a better doctor by learning non-doctor, non-clinical skills and perspectives.
Oh, wow.
Yeah.
I love that. One of my favorite articles that I ever read was on how it was a team of doctors that started collaborating with veterinarians to see what they could learn from each other's practices. And there's a lot that, doesn't translate. But they found an area that did, and it was in behavioral health. That they realized that a lot of the same sort of, especially if it was like a self-destructive behavior, that were being experienced among mammals were also being experienced by Homo sapiens and had similar outcomes because it was sort of getting at the reptilian brain, right? The not really the conscious part where there's an issue, and some of the therapies that actually worked for animals like would also help some people to overcome some of their issues. And it was like I'm like it's so wild how much different knowledge can be unlocked if we're looking at new types of analogies. We're learning about new types of systems that are almost always held in one area or another. The um, the thing that is uh, fascinating to me is we're trying to think about, okay, how do we restructure the system so that we can boost you and those who are doing the right things on the inside to try and realign things. And our first sort of three steps is first primary care. And I'm very curious to hear your thoughts on this, in that our thought is, look, we're like the first Homo sapien generation who is taking trust out of our core healing, where for 10,000 generations we had shamans and medicine men and religious, quasi-religious medical leaders who would practice non-science based medicine at all, but as a species we still had them in every society, and it was because it worked. And it's because placebo is real. I mean, cynically, it's placebo, but the reality is like placebo's pretty darn good. It's hard to beat a sugar pill. Ask any pharma R&D rep. It's hard to beat an M&M. And that's because trust is really powerful, and it can heal. But that we're like the first generation where people don't have doctors anymore. Gen Z like doesn't even know that that's a thing. They're like, the urgent care, ER, like what do you mean a doctor? Like they don't know what it is to have a family doctor. That concept is being erased generationally, and at least in this country. And so that's the first thing, is we're like, we've got to stop this from being extinct. We need to help people have a relationship of trust with a doctor who's affordable and accessible. And we have to bring that back in. And that's sort of the foundational piece that we're trying to recover right now. And then we can kind of build from there. But first, sort of pausing there, I'm so curious about your thoughts as a specialist.
Oh my gosh. Yeah, I have so many thoughts on this. In primary care, I have so much empathy for primary care because to become a cancer doctor, I had to first board certified in internal medicine, which is primary care. And I do see this trend that Gen Z is seeing where primary care doesn't really actually exists, because when someone goes to primary care, then they're just being sent to all these other providers for the organ systems because we're trained by organ system. So it's like, oh, your blood test looks off, so go see a hematologist, which I also do. So I do cancer, internal medicine, and oncology. But yeah, so I'll almost see all patients because all primary care will at some point have an abnormal blood test, or maybe their foot hurts, so they go see a podiatrist, or one of their they maybe did something that their liver number was off, so now they have a liver doctor. So the primary doctor is almost more in order to survive, because the knowledge base is too much, their own business base, like they can't really exist by doing the really good work that they probably intended to do, like take care of a human being. They can't really do their job. So they just have to start outsourcing all that very difficult cognitive work to all the subspecialists. And so now I and I look at it like this is not anyone's fault, but more our own making, as an entire village of trying to care for human beings. Is then I think specialists actually take on a lot of primary care work, and then they're looking at it like, why am I now doing primary care? And then some of us do try very hard, but then the problem is that trust is it's a beautiful thing, but also when the system isn't set up to honor trust, then patients will then come to that provider that they now trust for everything. And so that
Yes.
person is the functional primary care. Like I've seen like a gynecologist be the primary care. I've been the
Oh,
primary care.
hun. That's like a classic example.
Yeah,
But if you're taking care of a cancer patient and they don't have that foundation, it's like they're going to we're just, we're evolved animals. Like we trust, we're tribal creatures. We want someone to trust to help us when we're scared. It's what we do. And if we don't have that at the foundational level in primary care, but we find it somewhere in deep secondary, what are we going to do? We're going to latch on to that. And it's not the way things are, and it's going to deteriorate the quality of care that we receive and be a drag on the system for the specialists who don't need to be helping me with my gout. Like not a thing. Um, it's so funny you bring that up too, because I'm not above this. This is totally me. I had an infection in my left eye. I had an acanthamoeba infection. It devoured my cornea,
oh,
and
wow.
it took me 2 years to sort of overcome it, and couldn't see out of the eye for a while. Got a cornea transplant. During that time, I was working with a Dr. Iyer out of UT Southwestern. She's great. And guess what? I didn't have a primary care doctor. And guess what? I trust Dr. Iyer with my life. She cured my vision. She's like Jesus for me, right? And what did I do to poor Dr. Iyer? Every time something happens, she was sweet enough to give me her mobile phone number, and I used it. I abused that number inappropriately so many times. And that's that's what happens. And she's a saint, so she would still respond. She shouldn't have, and I was being inappropriate. I didn't realize it at the time. But but yeah, anytime something came up, she was the medical professional who I trusted with my life. And that's not the way the system is set. We need to give people a relationship of trust at the entry level, not deep into the system.
Yeah, I look at it like I take a lot of lessons from just trying to understand our human history and like you've been going back, which I love, taking all these different ways of thinking about medicine. But like I use this village analogy a lot because it is so apt. Where there's probably a time when children would run around, and then their neighbor could like say, "Oh, you're doing something dangerous," and then scold them, and the parents would be grateful and be like, "Oh my gosh, thank you for rescuing my child from jumping off a cliff." And it's like a lot of people could take care of a huge mass of children instead of each family walling off and saying, I'm going to take care of my child my way, and anyone who interferes, that's wrong, when it's really better for the whole entire society that we all be able to work together to figure out what are our values and align those values. And I feel that way about the medical system, where each institution or each group, we have the way that we want to do things, and then even each provider and their team, they have their way of how they want to do things. But I'm not so sure that's how we should take care of patients, not like patients are children, but that I think the system, like thinking about taking care of a whole village, we aren't fully aligned, and partly because the incentives aren't aligned that way, but to actually look at, are we raising the patient health, or are we more doing things that it just makes me feel like I'm parenting better? And a lot of the way that we practice and relate to each other, there's a little bit of that spillover. And I don't think patients know the system, so then they own it and they go, oh, like they don't care about me, or oh, this is for money, or they start taking on their own meaning. And so I find that the more that patients see doctors, and I hear it all the time, and I actually really fully empathize. It doesn't hurt anymore when they're like, oh, I'm done with doctors, or oh my gosh, this is not how I wanted to spend my retirement, is just seeing doctor after doctor. Or this is such a waste of my time and my life. And I always thought when I became a doctor that that would be who people love going to. Like, oh, that's my hairdresser. Like,
Right. Yes, it's your
uh,
trusted friend. It's someone that you
yeah,
that gives you so much value.
yeah. And but then the more I find trying to do that, the more I find that actually makes things worse because the system isn't aligned to allow that kind of a function. And so I'm not the Jesus like doctor who gives my cell phone
Mm.
out.
Yeah.
And if someone called my cell phone, I'd be like, who is it first?
Yeah. Yeah. That's right.
Yeah, but I also understand that feeling of, well, this person trusts me and maybe I should be doing that and like fight back against
Right.
the system. So then it also becomes very hard on the individuals, a morality issue. And I
Mm.
think a lot of providers, we're running into a shortage issue of providers. And it's not that we don't want to take care of people, but I think we thought we were going to be able to actually take care of people. And now it's more like, oh, but we also can't make someone else angry, or if we do something this way and we did it wrong, we're going to get punished. Or if I do something and it was with the best of intentions, but it didn't land that way or it didn't get perceived that way, then it doesn't even matter what my attempt was. So then there's a little bit of just that, okay, I picked the wrong field.
Yeah.
Yeah.
Oh man.
You're such a good
Oh,
listener. I'm supposed to be I'm supposed to be asking you things and you turn the tables on me.
I didn't mean to. It just happened. Uh, the what do you think about value-based care, and is it achievable within specialties? I think within primary care, we're seeing it with direct primary care. It actually works really well. You pay a low monthly subscription, you get unlimited access to your doctor, and the doctor now is very well incentivized to keep you home in bed, safe, and you don't have to come in, when you're sick and waiting room and sit on the butcher paper and the whole thing. Like you can stay home. But a little tougher to do in specialty care. I think fee for service probably makes sense, but are there ways that we can realign the incentives within cancer care?
Yeah. I do think about what is it that patients really want, and then
Hmm.
how could we, if we had a magic wand, wave it in a way where people get paid in a way to honor what it is that the patient wants. So if they like being at home, which immensely would agree that they would wish that they could just be at home for everything,
Mm.
then how do we deliver healthcare uh, safely, given that if they have some sort of an side effect, we can't really run over there and manage the side effect. And so that's the other difficulty about a specialty that involves mm, potentially toxic medicines, is that
Oh yeah, no, you can't do that at home.
they can't
I
do
mean,
it
you,
at
you
home.
might some of it maybe, but
Maybe
most of it you can't.
some. And when they take pills, we always feel like the amount of monitoring, like a way to allow us to know that they're actually doing it correctly. And I feel like this is being looked at, and there are shifts in the oncology world, like we call it electronic patient reported outcomes, trying to collect that data where they're telling us how they're feeling, and then we're changing our management based on how they're feeling, as opposed to the traditional way, which is we would look at them and look at labs and then tell them what we think is going on. And then whether or not there's enough time to hear what they have to say, but I think that's shifting where now we know patients live longer. We have data where patients live longer when they actually get to frequently report to us and we're responsive with supportive care. So I think being able to at least offer close enough clinics and have those clinics be very accessible, like not big, intimidating, uh, maze-like uh, buildings, but just a little parking lot, and they don't have to pay for it. It's just a little parking lot, and they go park, and then there's a little waiting room, and they go and they know everybody in the waiting room and they know all the staff. So community oncology, the model that I espouse, that I'm a part of, is community oncology, which that's all of the non-big centers, non-campus like centers, which is about 80-85% of oncology because it's where people are, where they live, the rural suburban communities. And so it's about building little sites closer to where people go. And I personally drive to some of these sites. And that way, by taking care to them, maybe not exactly to their home, but somewhat close enough, then we can tailor to something that's a little bit more aligned with their health rather than saying, oh, well, you've got a fever and I'm 5 hours away from you. Well, you're going to have to drive over here, which is just not safe. So I think the hard part is being able to have a sustainable model where we can create all these little sites. And in the current incentive world that we have, where it's not really going to be incentive driven to keep little clinics open, it's going to be more, let's have that very nice uh, building that is big and has lots of very ornamental features and a big name. So yeah, so I look at it like, how do we help bring that conversation back to, well, what is it that patients actually want? How closely can we get to that? And then how do we encourage the entire system to collaborate where it's not like, I mean, it's okay to have a piano lobby. Maybe you're just that good. I don't want to start a war with anyone who plays the piano at all. But also, if something is coming from patients, how are we going to be able to take care of what they need? Because at the very heart of what I think about is that in the end, we're all patients. Uh, at any moment, I could go home and find out I've got cancer. And so I would hate to compartmentalize what it is I'm doing. Uh, and I find there's a lot of that going on in healthcare.
Yeah. How do you work with primary care to make sure there's, assuming primary care is working the way it's supposed to, somebody has a good doc, how how does that change the way that care is delivered? Hopefully, you're not having to give out your cell phone, right? Like that, you've got some support there. You've got that community.
Yeah, primary care is very much in become nurse practitioners. So
Mm-hmm.
there's doctors who I find that they're constantly just trying to keep up with volume of patients. So they've got nurse practitioners, and sometimes patients will tell me that they just can't see the primary care doctor for even 2 years, and they're just with the nurse practitioner. And that nurse practitioner may be toggling with another one, so they see a different person and don't really build a continuous relationship. And if they do, I find that so rare that I'll oftentimes try to carve out time, and this is very hard to do, to call their primary care, especially when I just have that feeling like, oh, this is gonna go really bad if someone doesn't know that this is happening and I'm the specialist and I'm not able to take care of. Like I've had a case of someone coming in with an infection and they came to see me for a totally different reason. So I'm trying to reach their primary care and say, hey, I don't know if you realize this about your patient, and it's going into a weekend, and we need to figure out how do we take good care of this person because they don't want to go to the ER. And I understand why not. And so I do try to enlist primary care help and wave a little flag like, oh, in the flurry of busyness that I understand that they're in, there's actually something really urgent here that we need to all work together on. But it is very hard to do because then I'm that much more behind on people who have cancer who are there to see me. So the system just gets like ever like a quicksand feeling. And by people who want to do really well, like you said, with uh, before we got on our call together, that there are people who want to do really well, but they're just in systems that make it so that it's actually hard to do the right thing.
Right.
Yeah.
It's hard and expensive. Like you're paid less and your life quality of life goes down if you're doing the right thing.
Yes.
So the what are things that I can share with you to talk about how we're trying to turn that around and or make it better and would love to hear thoughts on your side as well.
Yeah. I really actually would love an a system that incentivizes my ability to talk to primary care and that we have
Mm,
that relationship. And then I see someone from Dr. So and so, and I'm just like excited. And
yeah,
I
because
go,
their relationship is there.
yeah, I go, oh, I'm excited to text them. I just saw your patient so and so. And I find that there used to be an era, and I think I joined medicine just as that era was eroding away, but we would all call each other about all our patients,
Oh,
or
wow.
we would say, hey, I just finished my note and I put all this stuff in there and I'm sending it to you, so please look at it. And I'm having a lot less opportunity, not so much because we doctors don't want to, but just maybe we'll call each other and someone's in the OR, or someone's on
Mm,
vacation, or we left a message, but then whoever we left the message with, it just got misplaced, or there's just so many opportunities to not be able to communicate anymore. And I would love a type of a system that says, hey, you're going to get, and I'm going to put it in the most crude way possible, but you're going to get
yeah.
paid to call the doctors that you work with, and
Yeah.
the time that you spend coordinating care, and the better that your patient feels about their care and actually their health is better, you get a bonus and you don't get penalized. No, as much as possible, no more penalizing or suing or
Yeah.
hurting people came into the field to just try their best to be helpful. That would be my magic wand that I just threw out at you. So
Okay.
thank you for
Challenge accepted.
saying that you're going to do
No,
all
that
that
sounds
for
really
me.
good. Where where are your practices located? Where are y'all located?
Yeah, I'm in Central Illinois.
Okay.
Yeah.
One thing that we're doing right now is our the thesis, the thought is, okay, let's lay the foundation, which is let's try and get every household a relationship of trust with an affordable, accessible doctor. Cool. That's our foundation. Then specialists becomes our second tier. So if we're doing the foundation right, we should cut down by about half how much we need to go into specialists. Because a lot of what specialists are doing is they're just dealing with the sort of the trust agglomeration that occurs with these patients who don't have a prime and they finally trust their specialist and that weighs that whole system down. So now if we've got a good prime, good GP at the front side, a family doc, we don't need to use specialists as much. So we can start to do that. And then for finding the right specialist, the thought is there's lots of good data that show practice patterns. Some, there's in bold, you may not have ever heard or seen of these vendors. Garner, there's one called GAM Vision that came out of Marty McCary's work out of Hopkins with the Choosing Wisely that pulls data on the practice patterns of 1 million specialists and shows the way that they are like basically the clinical judgments that they're making. And we're able to see there's a small percentage of doctors that will pop out of the data, out of these analyses that show that they are gaming the system, that they're doing a whole lot of rare, kind of bizarre, a little bit anomalous therapies that they'll do to every patient because they're very billable, they're lucrative, even though they're not clinically appropriate at all. And the physicians who have given up, who've sold out, pop out of the data very quickly because they're clearly practicing financial medicine, not clinical. And the idea, and then the doctors who are doing the right thing, even though it acts against their own incentives, they're doing the right thing for their patients, and to hell with the incentives. They're doing what's right by the patients. It allows us to see those physicians as well. And so phase two is working to get the lists in each community of the docs who are doing really good work, and then working with our foundation, our primary care foundation, to steer into those specialists so that we can fill the panels with appropriate referrals, right? Appropriate ones, not just, I have a bunion, help, but appropriate referrals to the doctors who we know are doing a great job. And along with that is finding a way to, ultimately finding a way to compensate them more generously. So you're getting more volume and better compensation per patient so that you are rewarded for doing the right thing. And then if we're successful there, the third and final is now with buildings. If we've got step 1 and step 2 doing really well, we're using very appropriate specialists, appropriately, which means about half as much as we might otherwise. And primary care is doing a great job with the relationship of trust. Now we've eliminated people going into buildings by more than half. So significant drawdown in facility usage, which is great. We still have to use them sometimes. And the idea is that if we can find the places that deliver great quality, and among those that are delivering good quality that have the lowest rates, ideally always pushing to an independent surgical center, infusion center, ambulatory, etc., not into the big building with paid parking and the piano. Not to be mean to piano players again. We've established they're
Very
people too.
important.
Yeah, we want to help the piano players. But we don't want our patients going into the palaces unnecessarily, and we keep them in the community. And if we do that, we could we've already eliminated the number of people who need a building at all by half. We might be able to eliminate that half by another 30% by keeping them in small facilities, community facilities, rather than the large palatial structures. And if we do each of those things really well, we might just knock out 40, 50% of cost. That might allow us to catch up with the European average. And I don't have proof, but I have to believe that it's going to have a wonderful effect in terms of life expectancy.
Yeah, and a lot of what you're saying would be amazing to happen on the outpatient side. And then there's also, as you probably struggle a lot with the inpatient side too. So once someone's
We
actually
struggle.
admitted into the hospital, and then there's a whole environment there too. Very similar environment, just lots of referrals, lots of diffusion of cognitive effort and spreading
Mm-hmm.
of, you know, who actually owns the patient and who actually is the one who owns the problem. So yeah, yeah, it's very helpful to know that you're working on this as
No,
well. Yeah, yeah.
I appreciate what you're doing on the other side. It's terrific to hear, and um, it's so reassuring to know that there are a ton of great specialists and physicians on the other side who are also trying to make the system better and orient around the patient rather than around the administrative arbitrage.
Yes, yes. And I'm just really hoping that our audience, we can even think of something tangible for them in terms of for providers. How could we be better advocates for our patients by understanding these dynamics that are right up your alley in terms of working with employers and helping them build that trust of who is it that they should work with? How do we help you with that trust representation?
I think that, first of all, for anybody who is a physician, who's a clinician who's listening to this and is thinking about, hey, how do I work more closely with employers? I think a good place to start is don't think big, think small. The funny thing is, small employers think, oh, no one cares about me, like they're not interested in my attention or anything like that. But most employers over 100 lives, coin toss, they might be self-funded, which means they are the insurance company. A lot of physicians don't even really understand this either, is that every medium to large size employer is an insurance company. They choose what's covered. They're the ones paying for it. It is not Blue Cross or United, Aetna, Cigna is the accountant. They're cutting checks, but they are not the insurance company anymore. The employer is, because that employer is now self-funded. And those self-funded employers wield enormous power because almost everybody who you see, regular patients who are in the commercial space, probably half or more than half are on self-funded plans where their employer is a baby insurance company. You just don't know it because they're selling flowers or trucking or they're a gas station, but they're actually, they're in disguise, but their secret identity is that they are an insurance company. They're a small insurance company. And it's actually much harder to talk to big employers than it is small ones, which is the opposite of what people think. People think, oh, well, a big company, they can easily do a direct contract or whatever, but I'm just small, that doesn't work for me. That's not, it's the opposite. It's much, much easier at a local level to work with a 100 Life gas station chain, right, that's in your town, and work with them to set up a direct relationship rather than going around it, because each of these small to medium-sized employers, they are self-funded. They are their own insurance company, and you can set up a direct relationship there. I think also partner with direct primary care. Direct primary care needs allies. These are people who are stepping away from the assurances of fee-for-service, and they're stepping into the unknown, into a very high-risk environment, doing a business model that is not supported by insurance, which means every patient walking around outside, from Medicaid to Medicare to commercial, none of it covers their services. They go all cash. These people are taking an enormous risk to do the right thing. They are firing insurance because they feel like it's destroying their profession. And they are the types of doctors who are 24/7 accessible to their patients. They're giving them their cell phone numbers. A lot of them are doing house calls. It's medicine as God intended, and these doctors need support. That's a big part of what we're doing, is trying to support the direct primary care movement. But those are the doctors whose referrals you want coming into your center, because those are the doctors you can email and text like, hey, I saw your patient so-and-so, they're doing great, just wanted you to be aware of X, right? Like, that's the type of medicine that you want. And so I would say with your, I don't think a lot of people are thinking of this, but with your facility, reaching out to the direct primary care in Central Illinois, I can help you find them, by the way, and saying, hey, we want to partner more with you because we're trying to do the right thing also. We know that you are, by virtue of the fact that you just fired insurance and are taking a step into the jungle of cash-only healthcare, which is takes enormous amount of courage to do the right thing. And so you're the type of doctor we want to work with, and we're the same kind of people. We're aligned on mission. We're not just trying to gin up billables. And so let's work together. And I think if you align with them on mission, because they don't care about, financially, they've already stepped into the unknown. They're looking for people to align with on mission. And if you show that you are aligned on mission, they will refer their patients to you. You do not have to pay them. You don't have to acquire them. You don't have to build a billboard. They want to know people who are mission aligned. And those allies, that's enormously powerful and can start to connect those dots, even in a fee-for-service or otherwise environment. It doesn't require the partnership with the employer. You can start to change things in the community.
That's amazing, Lee. Thank you so much for sharing that. In fact, once we're done with this podcast, I'm sure we'll put out some of the contact in your social media, so anyone who's
Yes.
listening can go, oh, I want to align in my region. Who would that be? And they can reach out to you.
Yeah, please. No, I'm happy to delighted to be able to connect people through. And I have employees in every city and every town in the country. We have 6.5 million lives. So I have employees in your town. I don't care who you are. If you're listening to this, we have employees in your town. And we'd love to start finding ways to build that collaboration. We'll start in Central Illinois. This is going to be fun.
Well, on that note, I definitely have to end because, now I have something important to do. So
Thanks, Dr.
thank you so much, Lee.